All right, case history is done. Now we move to vitals. Now remember, vitals are given in each and every post-encounter probe room, so you're going to know it about each patient. But a patient might give away that they're running a fever, so it might be a good question to ask if they're wiping their brow, because you might want to ask about night sweats or sweating at night or how high the fever is or whatever. Now when it comes to fever are elevated for both viral and bacterial, but viral can drop subnormal. So we call that fever and chills, fever and chills, fever and chills, where they get, they're just freezing. Now, when we talk about bacterial infections, they're a little bit lower during the day, but not subnormal. So they're really high at night and kind of not quite so bad in the day. So that high at night, very predictable, is what we call the night sweats. Now, you can have a really bad, maybe 50 minutes of sweating really bad, or 30 minutes of sweating, or 20 minutes, a short period of sweating with a viral. But the bacterial, you just sweat all night. You're just wet and a high-grade fever, and that's the way it is. Now, it isn't that you should go, oh, somebody has a fever, I think they have cancer, because that would be the wrong deduction, okay? But you should have in the back of your mind just a little bit of a fear about the fact that Hodgkin's and Ewing's are two cases that can show up in our office. One, the Ewing's could be a young person with some bone pain, right? Some knee pain or shoulder pain. So we want to be sensitive to that. But Hodgkin's is that patient that's getting sick quite frequently and is coming in for that immune boost that chiropractic can give, but it isn't making any sense, and their neck is swollen, and they're having peripheral nerve entrapments, and their arm is numb, and all of a sudden you're starting to put together that they have lymphomas in their neck that are swollen and Hodgkin's and running a fever, and it isn't just a cold, it really truly is Hodgkin's. So I want you to think about the fact that kind of in the back of your mind is those worrisome problems. Now when it comes to a pulse, I got a little quiz for you. Let's see how you do here. When it comes to pulse and respiration and blood pressure, those things can run a little bit high when people see a doctor or have chronic pain or just the insult of pain. So would you expect the pulse to be going up or down if somebody had Graves' disease? Now that's hyperthyroidism, Graves, hyperthyroidism, so it would be going up. If we're talking about a fever, your temperature goes up about, or your pulse goes up, about 10 to 15 beats per degree. So that's why when you're running a fever, you're just worn out. You're fatigued, you're tired, and you haven't done anything. And you go, what am I so tired about? Well, it's because your heart's working really hard. Now, during exercise, as you exercise, your pulse is going to go up. But because you regularly exercise, your normal pulse will be down. So during exercise, elevated. Okay, now holding your breath. And then you let your air out real slow. Shh. Exactly. It's a relaxation. It stimulates parasympathetics. That's why you take a few deep breaths to relax. So this would be a decrease. Holding your breath decreases your pulse. Respiration, I'm not going to say much about. You don't know what normal respiration is. Just realize, if somebody's breathing shallow or holding themselves or can't take a deep breath in, we're worried about some kind of thoracic rib cage or lung problem. When we talk about blood pressure, we're going to demonstrate blood pressure. So I want to just talk to you about the things on the page, and then we'll stop and do the demonstration. But when we look at blood pressure, you should know your normal values, and of course the new ideal is considered the 110/70. Even though when somebody's running 120/80, that's pretty normal for a lot of folks out there. But we would like to talk to them about exercise and diet and those kinds of things. So making that the ideal gives kind of doctors permission to do that. Of course, it gives medical doctors permission to start the drug therapy, so pharmaceutical had a little something to do with that. But remember that when you're talking about blood pressure problems, we want to think about the fact that medications can both be treating the blood pressure and causing the blood pressure. So medications is a big, important question to ask down here. And if you bring up the bottom of the page, Dr. Laura, before we show them how to do it, let's just talk about the fact that some good blood pressure questions are kind of listed here. What's your diet like, your exercise, what meds are you on, do you have any diabetes or any other systemic diseases? But I want you to be very sensitive to clot issues. And the two clot issues, DVTs and strokes. Now the big one is the heart attack, but we'll talk about that at the heart page. But when we're talking about DVTs, we're usually thinking of somebody's lower leg, their calf. And so I want to talk just a little bit about the fact that you've got to ask about, have they been immobile for quite a long period of time? Did they just fly from Australia? Did they just have a long car ride? Did they sit in 4 movies this afternoon because there was a movie Rama on or something? I don't know. Or are they on hormone replacement therapy, or even the fact that they might be on some kind of women in birth control pills, so any kind of hormone, but usually it's older women, so I went to hormone replacement therapy because that's the more traditional group to get them. Now remember, to confirm it is the ultrasound. It's going to be a refer, and what we're worried about is the pulmonary infarcts. This case has shown up over and over and over again, so that's why I wanted to make a special note of it. And when we talk about strokes, that's shown up over and over again. So this is that person that we think of fast, right? First the face kind of droopy, then the arm isn't working too good. Maybe they're talking about speech problems or they can't talk, and timing is of the essence. We got to get them to the hospital within those first 2 hours, and then we get a pretty good result if we can do that. Remember, the patient may claim it's the worst headache I've ever had, so that's a real common complaint. Now, we're going to demonstrate how to do a blood pressure, so let us get ready for that and we'll show you. Alright, now we're going to demonstrate the blood pressure. When you do the blood pressure, there are two kinds of cuffs that they may have available. They're rather fond of this one, which has two tubes. So when there are two tubes, you'll have to find that one of them, okay, and that'll be the one with the sphygmometer on it, is the one that you want to find this little hook up here to put it on. When you have one with one tube, if you'll notice, it's already inserted or attached to the cuff itself. So if you find yourself in this dilemma, just realize you've got to find the one with the meter on it and hook it in. And even these usually have a hook or a place for one. This one doesn't, but often they do. So you'll find that hook's probably even on yours at home so that you can kind of see where that is. Now let's talk through step by step, and you might want to add a few things if you're feeling a little weak in the knees at this. But let's talk about why a blood pressure is done. A blood pressure is done to find the working rate and the resting rate of the heart. And so what we want to do is find the true work and the true rest. So if we just pump up and then just let the cuff out, what we might miss is a true systolic value or work rate of the heart, because they might have an oscillatory gap, which is an area that lacks any Korsakoff sound. So we may not hear or get the true systolic value. So our job is to do this. Okay, so I'm going to take you step by step and show you what your job is. I want you to go over and get the stethoscope and put it on properly, okay, and realize that you want to make a little noise if you want to hear it, okay, and make sure you're using the diaphragm. Now, do you remember we said that the bell is used for vessels? This is an exception to that rule. I know that some resources, that's buzzing, Dr. Laura, some resources are going to say that you can use the bell. Some resources are going to say use the diaphragm, but almost everybody uses the diaphragm. So I'm sure you want to look like everybody else on your test day. So use the diaphragm, and that'll take care of that. So get the stethoscope, get it mounted, get it on your neck, so you're all set to go. You can even have it close to your ears, but I don't want it in your ears. Okay? Now there's a reason for that. Then find whatever cuff they have available, and the next thing that you want to do is make sure that you've got your cuff prepared properly. So one of the first things that we do is get all the air out. So get all the air out by loosening the valve and then doing that. So just find the one with the valve, the pump, loosen it, get the air out. Then you're going to go over to your patient, and the prep for the patient is that you want them to roll up their sleeve if it's a little too long, or if they have a t-shirt on that's hanging down. So you'll want that area prepared for you. Then have them extend their arm out. Now your job is to find where it says artery, which if you don't see it on there anywhere, it's close to the tubes. Always close to the tubes. Okay, you're going to place that on your patient just a little bit above the cubital fossa. You're going to try and make an effort to make it nice and tight so it looks like you've done that, because if it's loose, you'll get a high reading. Then you're going to do something very important. You're going to take this person's arm and you're going to lock it with your elbow at a height above their heart. Remember, they're sitting on a chiropractic bench. So there is no table to set this on, and to do it properly, their arm has to be above their heart. So this shows that you understand that. Now don't bring it up into your armpit. The rooms are hot, you're going to be sweaty, and that's rude, okay? So don't do that. So down here, lock and load. What we don't want to do is this, because that invades the patient's personal space. So now you're suable, and remember, if it looks like you're doing something really egregious that you could be sued for, then they can fail the entire room. So you can lose a whole room over some stupid, silly, bad behavior. So I want you to realize then, kind of take a picture of this or lock and load this in your mind and realize that this is the proper position. Now the next thing you're going to do is pump this up, but if you'll notice, I'm palpating his radial pulse. So I'm going to pump it up till his pulse disappears. That gives me not the fake systolic value, but the true systolic value if he has an oscillatory gap. Now that means I palpate on the way up. Now normally after I get that, I'll put his arm down, loosen this, take it off, and I wait 5 minutes, because after palpatory systolic, we let him move around a little bit, then we do the actual blood pressure cuff. But you don't have time for that. So here's what we're going to do. Here's how we're going to fake it till we make it. Okay, we've got him in the proper position. We pump, 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 pump till we hear it, till we feel it go away. Then we're going to slip this in our ears. Okay, we're going to place that there, and the best thing to do at this point is ask the patient to hold that. Would you mind holding that, Ben? And you see, patients are very accommodating like that. So then you can slip this in your ears, do what you need to do, get this over here, shh, boom, 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 all the way to 0. Okay, go ahead and relax. Okay, so that is the proper method to do a blood pressure. So let's start from the very beginning and do it all again. So we are going to go over, get the stethoscope, make sure we're prepared to use the diaphragm. We're going to get this. We're going to get all the air out. We're going to make sure it's hooked up properly. We're going to have the patient prep themselves by rolling up their sleeve, extending their arm out. We place this on as snugly as we possibly can. Okay, we lock and load the patient in the proper position. Pump, 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 pump till it goes away. We slip this in our ears. Have them hold this if we need some help and support so we can see this. Shh, all the way down to 0. Now, if they ask you what it is, tell them 120/80 if you can't hear anything, okay? But I will tell you that it should be close to their age. Like, he's probably about 16 years old, so we'd say 116 over about 80, 82, because it runs a little high when you have it repeated. So just in case, all you can hear is your own heartbeat, at least you can fake it once again till you make it. So kind of review that, practice a couple of times, realize there are 2 kinds of cuffs that can show up, and remember to use the diaphragm. I'd like to show you something about the blood pressure itself. We know that there's Korotkoff sounds, that this one representing systole, this one representing diastole, so the working pressure, the resting pressure. We know as people get hypertension that this climbs, 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 so that we see this getting higher and higher, and this usually kind of lags behind and elevates with it. So as we see the diastolic elevating, we know we're getting in pretty advanced stages. But people can have an oscillatory gap. Remember I said that. So if you just pick a number and come up here, you might think that is actually systolic. That's why you have to do palpatory systolic, so that you get that true systolic value. And you don't want to call this diastolic, so you have to listen all the way to 0 to get the true diastole. So palpatory systolic, listen all the way to 0, and you will get true systole and true diastole. Alright, as we finish the vitals then, the 2 that kind of aren't mentioned a lot, but they're still part of it, is height and weight. If we talk about height, what do we anticipate? That a child is going to get taller or shorter? Okay, time's up. You should get this one right. All right, so kids are going to increase, and we want to monitor their growth and development and make sure that things like scoliosis aren't progressing rapidly in a growth spurt and those kinds of things. In Paget's, do you think that they're increasing or decreasing their height? And some of you are probably on both sides of this coin, but I want you to realize even though they're thickening their cortex and enlarging bones, the bones are getting weak because they're not made out of calcium, they're made out of phosphorus. Remember, cheap bone, Kmart bone. So they're starting to bow all these long bones and getting shorter and shorter as they bow their legs. So Paget's, shorter. And osteoporosis with the hyperkyphosis or dowager hump is shorter, so that one's pretty obvious. Then I've got 2 words for you, cachexia and anorexia. And if I were to ask you without looking at the rest of it, which one's more dangerous, they're both weight loss, but cachexia is what we call the wasting syndrome, where you've lost about 15% of your body weight within 3 months, but you're still eating. So realize anorexia is weight loss with a lack of eating. So there's a reason you're losing weight. Maybe you don't feel good, maybe you've worked hard, maybe you've mowed the lawn or something, or maybe you're scared of eating because you have anorexia nervosa. But cachexia is always an indication of something really ugly going on, such as cancer. Something's eating you, even though you're still eating food. Then we've got weight loss that's unexplained, and I've got weight gain that's unexplained for different age groups, so I kind of took care of you there. But a very important question that you see Dr. Laura kind of bringing up from the bottom, can you come up with these 2 answers? Top 2 answers. Provide 2 reasons for unexplained weight loss in patients over 40. Now I bet you most of you come right out and say cancer across this top line. And of course then that covers a large, breast cancer, lung cancer, metastatic cancer, multiple myeloma, all kinds of cancer. So cancer, rather large group. So what large group would you put for number 2? Because a lot of you are maybe saying diabetes or this or that. But I will tell you, probably the right answer here is endocrine. Because that's going to cover a lot of hormonal things for females. It's going to take care of diabetes. It could take care of a thyroid issue. So probably unexplained weight loss, endocrine's a pretty good answer. In fact, unexplained weight loss and gain, endocrine can answer both of those questions. So remember, it's really a part of your basal metabolic rate and how fast you're digesting and your metabolic pacing yourself.